So the reason we've been trying to talk to this is basically because one of the things that I do is a lot of the times when I see patients in the office and they send us their records, which could be anywhere from 10 to 20 to
A book.
to 600 pages long.
Yeah.
It's we kind of go through the 50,000 questions that we ask them. They fill a packet and we can kind of go from there.
Right.
And then even sometimes when we're just doing that evaluation, one of the things that I tell them is like, okay, I want you to come down to see us at the center. But more importantly, I actually want you to take that same time to call your office so that at the same time that I'm evaluating them, that they can come and see you. But in the end, one of the things that I find with some of my patients is like, yeah, but I have pelvic floor in my close to where I am. I was like, no, 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 no. No. This is a totally different thing.
Right.
It's a totally different mindset. It's a totally different group of patients. It's a totally different approach to pelvic floor. This has to do a lot of nerve blocks, but I just kind of want you to like take charge and go through it with them. And I'll ask you 50,000 questions as well.
Absolutely.
But that's it. That's it. Tell us.
Absolutely. I mean, when it comes to endometriosis, obviously it's a beast of a disease, and it will commonly affect the pelvic area. And within the pelvis, there's so much. So we have our organs. That's what a lot of people think about: the uterus, the fallopian tubes, the ovaries, the bowel, the bladder. But then there's so much more surrounding that and protecting that. So we have our pelvic floor muscles, which primarily levator ani is the big ones that we think about. That's the sling that's kind of holding everything together. It's connected to our back muscles. It's connected to our abdominal muscles. And then we have all those nerves that are embedded within those pelvic floor areas. The big ones are pudendal nerve. There's the posterior femoral cutaneous nerve, genitofemoral nerve, ilio and hypogastric nerves. And so when it comes to endometriosis, which is such an inflammatory disease process, these other areas are also getting affected. So the muscles, the nerves, and our body is trying to protect itself. It's trying to react from it, but then it in itself can create a whole separate, pain complex that causes pain beyond even that endometriosis, awful pain. And also other symptoms of bowel and bladder dysfunction, pain with intercourse, even pain with sitting, pain with movement. And so again, I also come with a slew of questions. And so it's kind of a matter of kind of peeling through those layers. And it's very rare that it's one and not the other. It's such a mix of things.
Yeah.
And so, an appropriate approach is kind of do it all together, right? Get your pelvic floor in that inflammatory process calm down as much as possible. Try to create new habits, including your biomechanics, breathing patterns, even, the way our posture is sitting, and diet changes, all the things to improve that environment so that when you come out of your excision surgery, you can have kind of the best long-term outcomes.
Yeah, but I mean, it's also important to kind of make sure that, like I tell my patients that even now, but also when I was in St. Louis, I would used to send them to pelvic floor weeks or months before they had surgery.
Mm-hmm.
And it's the importance is that we can optimize all those other things that are also hindering, because when I usually do this, and some of my patients that have been here to see me in the office and probably some of my talks, I have this thing and I do this for every patient. Like we draw everything, we have all the models, all the pelvic floors and everything, and I give it to them so that they can have a better 3D understanding of what their pelvis is and how to go from one side to the other. Like it gives them that knowledge of what to expect. But it's always important that when I talk to them, they have to understand 5 things. There's 5 different things that can give you pelvic pain. Gynecological origins are one of those 5 things. So we talk about bowel, right? Chronic constipation, chronic diarrhea, Crohn's disease, ulcerative colitis, and small intestine bacterial overgrowth. Like 50,000 different things from the gastrointestinal point that can cause massive pelvic pain, right? Then we go and talk about the genital urinary issues, right? So interstitial cystitis that's associated to endometriosis around 69 to 70% of the time,
Right.
right? In IC, you may have findings that you may see it in cystoscopy, but it's usually a clinical diagnosis, right? So all these things is why I sometimes want my patients to come in here and see us, and I'll send them to go to see our local urologist, Dr. Greenstein, who's phenomenal. And he
Absolutely.
would start optimizing these things even before we go for surgery, because it does a world of difference. Actually, it makes me look really good at the end. But more importantly, like we're actually chipping at all those little things in their pelvis that are pain. Then we go basically through the whole gamut of the gynecological organs, right? It could be endometriosis, it could be adenomyosis, abnormal cyst, it could be fibroids, cancers, polyps, like uterine anomalies, right? Like vaginal anomalies, like all these other things that can cause these issues. Then we talk about chronic pelvic pain syndrome, central pain sensitization.
Right.
And then we start talking about pelvic floor, like musculoskeletal pain and all those things that entail pelvic floor, nerves, pathways. And now the last thing I'm actually talking to them about is, and I added this for the last year, we're talking about the pelvic floor dermatomes and the dermatomes of the legs.
Yes.
Because a lot of times patients are like, well, every time I get my period, I get pain on this leg, and it goes through my inner thigh and it goes through my big toe. And I was like, tell me again. And then we start mapping out where that pain is. And I tell them, well, the nerve that controls that area of the body is this. And it's such a great thing when they're like, wait, so this could be one, this is sciatic, or this is the general femorocutaneous, or lateral femorocutaneous, or the inguinal iliohypogastric. And we start talking about all these things specifically because a lot of the times when we go in for surgery, like we sometimes find endometriosis on one of the most common nerves to be affected by endo, which is the inferior hypogastric nerves, right? That go to the bladder. And we tell them like, hey, like this is part of your disease, right? The chronic inflammation that we find in pathology. But the most important thing is that I always want them to come here and see you, meet you, and then get to know all the wonderful things that you could do for them and how you can improve their lives even before we go in for surgery, because it's the starting stone to what comes next.
Absolutely. And how you mentioned kind of how everything's so connected. It's amazing to see when we examine that patient, when we put our hands on that patient, how that exam reproduces what they feel, right? If they're hurting in a certain area and you push on that deep area with the Alcock's canal and they're like, okay, that reproduces my pain. And now I'm also feeling that pain on my toe. And I'm not crazy for saying, hey, my pelvic pain comes with my toe pain. I see that very often. And it's just kind of the way our bodies are created and how these nerve pathways are connected with each other. And so as we kind of peel through those layers, addressing the endo part, addressing the nerve part, addressing the musculoskeletal part, the goal is, again, function, and getting these people, back to that quality of life that they deserve. And again, I wish to say it would be a easy process, but it takes multiple steps. And to optimize everything before surgery can be really helpful. We call it kind of prehab. People do it before hip surgery or knee surgery. It's very common in the orthopedic world, but in the gynecological world of general surgery, we never think about like, okay, let's optimize our bodies prehab so that we have the best surgical outcomes.
Actually, I'll steal that from you. That prehab, I'm going to steal that from you from now on. But there's somebody posted a question recently that and it's what I mentioned before. Like they're basically saying that even before they go in, even if they've had pelvic floor physical therapy before they get to us, like I still a lot of the times want them to see you. And it's like, and my nurse has asked me, okay, she's coming to see you. Is she coming to see Dr. Taylor at the same time? And I was like, yep. Because it's a different approach, right? My visits are long, right? And they've been long since I trained here, since when I went to St. Louis. And my visits were usually an hour, sometimes an hour and a half. Sometimes my AMA is like, hey, I'm going to go to lunch. Like, you do you, and I'll come back when you're done. And she goes to lunch, and I'll stay talking to my patient for hours because I want them to understand everything that has to go on that has to be managed for their disease to improve, and that's why we talk about so much about going to PM&R, because of all the wonderful benefits that it does. But one of the things that I tell them is like, you're not only you're not going to only be basically having them do exercises. Like you do blocks, you do injections, and they're like, wait, and she's going to do injections? I'm like, yeah. She'll identify the specific dermatomes in your legs, because I can't. If I had to do that, my consults are going to be 2.5 hours, right? So I take an hour and a half with them. You take another hour and a half, and then just mapping out their dermatomes. And in all honesty, like the notes that you send are phenomenal. They're like very long, very detailed. Go by nerve bundles, structures, like this is the sciatic. And one of the things that I'm starting to do with my patients, some of the things that I've actually learned recently or in the last year, is to observe the patient walking. When they go into floor, I see them in my office, and then when they go to their room, I'm watching them walk from behind to see if they're limping, if something's happening. And I talk to them about, how do they sit? Do they sit flat on their butt, or they're more a little bit to the side? Right. And sometimes that's the first time that they've been asked these questions in which they're like, well, nobody's mentioned that. But yeah, now that you mention it, I can't sit flat on my back, on my butt, because I get severe pain. So why is that, right? So that's the importance of having them see you at the same time that they see me, or sometimes they can't, but I still have them see you after surgery, right? It's better if they do before, but sometimes for time constraints, if they're coming here for a short time, sometimes it's better for them to see you after surgery as well.
Absolutely. Because again, there's, like I said, so many parts with the SI joints, the hip flexors, the pelvic floor, the muscles, the obturator. Obturator can be a stubborn one. And again, a big thing that we do is we do an injection series on a lot of these patients. Our injections are a little different than your typical, maybe it's a nerve block or a muscle trigger point or Botox or anything like that. Ours are guided, or ours are intended to do a combination of both. So we want to address the nerves and the muscles together. So when we do injections, number one, it's determined based on their exam. So depending on which nerves and muscles we need to target, but we also do it in a series, because again, one injection, like I said, I wish would be a magic cure, but again, these muscles and nerves require a retraining process to get everything calmed down, that inflammation calmed down, get that overactivity of the myofascial tension calmed down, but also that over hyperactivity, that central sensitization into that peripheral nerve calmed down as well. So when we do injections, number one, they're guided. So I do use an ultrasound to make sure it's as precise as possible, getting to the right space. Number two, they're external. So we're not going inside the vaginal or the rectal area to do this. They go through the butt cheek area, the gluteal tissue. So it kind of feels almost like a flu shot type of thing. So we try not to make it invasive as possible. And the other aspect is, again, it's done in the office. They're pretty quick. You don't necessarily need to have a driver or anything like that. And our goal is, again, to keep you as functional as possible. So the injections also paired with physical therapy. So I know a lot of our patients will have a local pelvic floor physical therapist, and we both share patients that are coming from out of state to see us. So getting that in combination with this is always helpful. Sometimes including those nerve medicines on board as well, because again, this is a diffuse process, right? It's not just localized to the pelvic area or just where the endometriosis is sitting. Sometimes our body gets used to this pain, and so incorporating neuromodulators can help with what we call the down training process, suppositories, and all the other tools, because again, it varies from patient to patient. We have services including behavioral health therapy, different ways to help downtrain the nervous system as a whole. We have nutritionists as well. So again, maximizing all the tools in the toolbox in order to get things in a better place. Part of it is the active things that I'll do in the office, and then the other things are going to be active things that the patients will do at home as well.
Can you touch a little bit? You mentioned something that I talk to patients a lot, and basically it's it's what is central pen sensitization? Like, can you
Yes.
explain it in layman's terms? Because the patients
Yes.
are like, especially when I'm talking to some of my patients in the Caribbean or in Central America, South America,
Yes.
we talk a lot about like it's not only it's having your electrical wiring for your body just
Mhm.
hypersensitive to absolutely everything. But can you kind of talk a little bit more about that? Because I know that's something that a lot of patients
Yeah,
want to know.
that's a huge topic. So, it kind of in layman's terms. So, let's say, again, let's say it's the endometriosis that's triggering a certain nerve. However, this has been going on. Again, it takes often, unfortunately, 10 years to make that diagnosis. So a patient's been dealing with this for several years. So that initial nerve irritation is communicating through the spinal cord, up the spinal cord and into our brain. And then that brain sends that signal back down. So if those signals are just keep going back and forth up the chain between the outside nerve, the spinal cord, and the brain, your body's gotten used to feeling this. So normal things that necessarily would not hurt, just a light touch, all of a sudden become so sensitive because your body's just used to dealing with this pain. And so the signals are just overfiring. And over time, your body outside becomes sensitive in order to kind of appreciate that pain. And so to assess that, sometimes I do a Q-tip test in the vulvovaginal area. But again, even when I push on the belly, sometimes I'm pushing so lightly and the patient, my patient is so uncomfortable. So that's an idea I have where, that central sensitization is really affecting day to day, even like, putting on clothes become painful to that patient. So that's a big aspect of getting that calmed down because your body's almost in this fight or flight place from that overactivity of the nerve.
Yeah. Um, so how do you start your evaluations?
So I usually have the patient just, start from the beginning. I say, tell me when all of this started. And sometimes, patients may have this idea, oh, it was last year, it was on this date. But then sometimes if that happens, I may have the patient pause a little bit and I'll ask a little specific question. I was like, well, tell me about like when you were younger. Tell me about like when you first got your period, or, tell me about all of this. So I usually have the patient talk a lot, but in the middle of things, I may ask for clarification. And so a lot of our initial appointment is spent just to getting to know what they've been through. And then I may fill in a few gaps that they might have not necessarily just shared openly, sometimes, bowel habits, bladder habits, intercourse. So we go through kind of all of that. Sometimes even things like, what do you do for exercise? What do you have any hypermobility? Because hypermobility can often come with endometriosis or even pelvic pain in general. How's work? Is work stressful? Is asking about stressors and things of that nature. So that's the first part. After that, I have the patient change and we do a neuromuscular physical exam. So I start with the back. I check their range of motion. I check for areas of tenderness, the spine, the SI joint, the glute areas, the IT band, the piriformis. So those get examined. Then we do a strength test. We check sensation. I check the hips as well because, sometimes labral tears can happen or be very common with pelvic pain. So check hip range of motion, special tests like Fadir and Fabir where I move the hip and internal and external rotation to see if that elicits pain. Then I check the abdominal area. I tend to start, if the patient's telling me I have a lot of left lower abdominal pain, I'm going to start right upper. So I'm going to start further away from where they're telling me and work my way down.
Yeah.
Check for hernias. Sometimes that can be a little tricky because hernias can be hiding. Diastasis. Then we're looking at the nerves. Those ilioinguinal nerves are right at the abdominal area, genitofemoral nerves. Then we do the lower pelvic exam. So externally, like I mentioned, it's a Q-tip test. So the Q-tip test for females is basically when I should have had a little drawing, but basically I'm using a Q-tip to touch upon that opening of the vaginal area, that vestibule we talk about. So we look at that area like a clock, and I start kind of at 12 o'clock and work my way down to see if there's that hypersensitivity, because again, a Q-tip should not hurt. And sometimes that will also allow us to look at the tissue. And sometimes the location of sensitivity at the Q-tip test can also give us an idea if there's a hormonal component to their pain, because oftentimes a lot of endometriosis patients have been on birth control for years and years, and that birth control is affecting their normal estrogen, testosterone levels, as well as their sex binding globulin, and that affects their vaginal tissue, the lubrication, and that can also be a reason for some of their, the vulvodynia symptoms. So, and then oftentimes the lower half of the Q-tip test tends to be more nerve related. Again, that's not 100%, but gives us a good idea of what, if there's a certain half of the vulvovaginal areas that's more sensitive. And also when going back to the Q-tip test, obviously pain is something we consider abnormal, but numbness is also something we consider abnormal as well. So we want to make sure you're feeling it, but also not hurting, but also feeling it. Then we check some outside nerves. So again, we can evaluate the inferior clonial branch of the posterior femoral cutaneous nerve, kind of at the ischial tuberosity area. A little bit higher, the perineal branch off of the pudendal nerve. A little bit higher is the dorsal branch off of the pudendal nerve. And then we'll do an internal exam. So usually my internal exam is just my finger, not using any special tools, but that internal exam, I will check the strength of the muscles. So we'll have kind of the squeezing and the relaxing. Again, I don't expect it to be perfect or anything like that, but what I often see with my overactive pelvic floor patients is their squeeze is not too bad. When I have them breathe and relax, those muscles don't want to let go. And then we'll check the tenderness within those muscle areas. So those deep levator ani muscles, there's iliococcygeus, pubococcygeus, puborectalis. There's the obturator also within there. So I'll feel for those areas, check for any trigger points, tender points, that vaginal canal, looking for vaginismus. And then also the nerves that are within there, that deep, pudendal nerve is deep within the Alcock's canal. So that's something we'd be able to palpate in there, feel around the bladder area. And that's the gist of the exam. I try to make it as comfortable as possible. If anyone's ever completely fearful or against that internal exam, I respect that, but obviously it gives us a lot of information.
So one of the things that I love for what you just said is, number one, it's very detailed, but more importantly, we tell patients a lot of the times that way before we touch them, we're actually talking to them for a very long time. And in certain situations, and this is something that I used to do a lot more in St. Louis, and which that I would see local patients, so it's easier. I would have the first visit just to ask questions, do a story, review their records, go over their pictures. And when I did this for them, right, I would basically, from this, once they had that 3D picture in their mind, we would go to their pictures from the surgeries that they already had. And we go, okay, this view, this is what this is looking. This is the before, but you see how sometimes the after, especially when the doctors do ablation in some of these locations, where some of these nerves could be hiding, or not hiding, but that's the kind of the trajectory of the nerves, but they stay very superficially.
Right.
So all that chronic inflammation and fibrosis is pulling on some of these things. So when patients see these nerves that you're talking, which is very advanced, right? But when they see that, well, if you have pain here, this is going to translate to pain on your inner thigh and your labia, close to the clitoral hood. This would be why orgasms would be painful. Mm-hmm. This is why, and teaching them specifically how to differentiate between pain on insertion during sex or pain during deep penetration.
Right.
Because there's both pain with sex, but it's a totally different thing.
Absolutely.
And one of the things that I tell patients, or patients tell me, specifically after they go through the whole rounds of injections and the therapy and they get surgery. Because I get a lot of patients or a lot of women in their mid to late 30s or early 40s, where it's usually where women start actually enjoying a lot more sex. There's not like, oh, let's turn off the light. No, 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 no. This is what it is, and this is what you're getting, and you better love it, right? So that confidence that women get after they're 35, it's so hard when they don't experience that sexual maturity because they're in so much pain for such a long time. But then after therapy, a patient said this to me a couple of weeks ago, that after therapy and surgery, now her libido is through the roof because she's like, okay, suddenly, because it's super easy for us guys, we go have sex, and after that, like hug, cuddle, and then bye, right? But for the girl is more, oh my God, I'm gonna have to pay for this. Or if you want to have sex or you want to have sex to please your partner, then in your mind is like, well, what do I have to do tomorrow? What can I live through this pain that is not going to kill me? And it's such a sad thing to hear when patients tell me, right? Because for they would be thinking of, well, tomorrow I have to take the kids to the game, and then I'm going to be in the stands, and I'm going to be doubled over in pain. I may not be an effective like cheer for my child, or like all these other things that could be the repercussions of intercourse, right? So that's the importance of getting these things in line so that you can enjoy your satisfaction better. You can have a better connection with your partner, but also identifying that pain from this can affect both deep inside and superficial, and there's different nerves and different things to treat, right? So that's the importance. Are you doing a lot? Are you doing uterosacral blocks?
We are not doing that right now. Not as commonly.
Okay. Okay. Well, so good. I mean, if then that's something that maybe I can talk to my patients about. I wanted to ask you that question, but it's so if you're doing all the others but not uterosacrals, that's something that I could do at the time of surgery and just do a uterosacral block.
Yes.
And that way, that deep pain, especially after cutting out that endo.
Yes.
I did a surgery today on a patient, and it was such a sad thing. Like she had endometriosis in 2020 and 2022, and I have the pictures in which they show the disease under both ovaries, very little, and they burned some spots and left it like that. And then what I saw today was bananas. How that stuff just exploded. So I have to start doing this before and after so patients can actually understand that when they become basically victims of ablation surgery. Right. So yeah.
Tell me, what is your threshold for reoperating on a patient, whether they've had an ablation versus an excision before?
Well, the problem is that I don't consider ablation of endometriosis surgery, right?
Yeah.
I mean, I see it all the time. I see when they go in and they burn a spot here and there. Unfortunately, because there's no real way to say if you're an endosurgeon or not. Like there was people that are saying, yes, I do endometriosis, and then like I think I had a couple of posts in my phone.
Yes, I've recently seen those. Yeah.
But I have way more stuff to post than I actually do. Like, but when I put something, it's because I'm like up to here that day, and I'm beyond frustrated, which is why I have a couple of friends that are calling me Mr. Grumpy right now, because every time I post something on, it's so sad because it's like it's crazy. I have patients that go to a doctor that they do endometriosis. They're on a list on Facebook, and they do the surgery, and then suddenly all the stuff is left behind. And I'm like, well, it's not fair. Because then patients don't know, right? So if you go and say that you're doing surgery for endometriosis, and then you say that you're doing excision, but the amount of specimens that go to pathology is 0, what did you do? Right? So that's kind of why we get so annoyed by this whole thing. I'm trying to figure out to call myself something different than an excision doctor, because it's like right now there's no difference. Like there's not a lot of difference between people that actually say it and people that do it.
No, I hear you.
Right. So which is, I think, why a lot of patients that undergo ablation of endometriosis, and they are sent to, after their surgeon, they go back to their surgeon saying, hey, okay, you did my surgery. Oh, you don't have any endo. I took care of it. I treated everything. Right. Meaning I took one biopsy, ablated 7, and then the uterosacrals are still littered. The rectovaginal septum are still littered. The inferior hypogastric nerve from both sides are littered. Everything's stuck together. but I treated everything, right? And then once, because I already treated everything, I already did surgery in 30 minutes, mind you. Then after that, they'll send those patients to physical therapy. And then they'll blame the therapist why they're not getting better, which is bananas.
Right.
Like they would not do the proper surgery, and then, oh, well, I did the surgery. I don't know why you're not getting any better. It's because of the physical therapist. They're not doing their job. I was like, wait, what do you mean? And then we do the surgery. I show them all their pathology. They have 10, 15, 20 specimens that are positive. And then suddenly, after the first 5 sessions of physical therapy, when they go back again, which they do so reluctantly because with
They've
their
been, yeah.
because they did not get proper surgery in the beginning.
Right.
But then if they don't get the proper surgery, PM&R is only going to get them so far, or they're going to have to come back and keep getting injections or
Right.
treatments. But one of the stuff that I love about you is the fact that you're actually also combining the therapy with the injections, but also vaginal therapy, right? So what are some of the suppositories that you give patients that can help them in spasms? Because you're also identifying the different types of pelvic spasms. It's not like, oh, no, you have spasms. No.
Yeah.
You have this specific spasm, and this is going to help, and this is going to do this.
Right.
So can you tell us a little bit more about that?
Yeah, so oftentimes suppositories can be helpful. So I like to include both muscle relaxers and nerve medicines in them. So I think Valium's one that a lot of people are aware of, and some may get Valium suppositories, but combining Valium, baclofen, and I like to use gabapentin for the nerve medicine, can help more long-term. Valium, ideally, you do not want long-term. Again, obviously, we're using it vaginally. It has less of a systemic effect, but again, a little bit may cross the blood-brain barrier. We don't want it on board forever. So a lot of patients will use these during the injection series, more during their active rehab process. Many of the patients will be able to wean off and use as needed if needed. However, some patients may need a little bit more long-term medication. So what I sometimes will do, take that Valium component out and just keep the baclofen gabapentin. Or sometimes, I have a lot of patients benefit from CBD in their suppositories.
Ooh, good.
So
good.
yes. So adding a little CBD into the suppositories has been helpful, and it doesn't make, often, not everyone's chemistry is different, but it doesn't make people feel sleepy, groggy. So it can be used on an as needed basis, like on the day of their period or something of that nature, where they still need to be functioning and awake. So I'll include suppositories. And again, I tell patients our goal is not for you to be dependent or reliant on them, but the goal is for all of this to work together in order to get you more independent, as opposed to not being able to go to work, not being able to, care for your kids and function and have pain as the top priority in their heads. Some people will use vaginal suppositories just right before intercourse. Or again, the suppositories can be used either vaginally or rectally. Rectally, it kind of absorbs a little bit better and kind of goes a little bit deeper into the pelvic floor area.
Okay. What do you do? So one of the things that patients sometimes tell me is like, when I'm trying to send them to PM&R before they've ever been, they're like, is that Kegels? Like, I already do Kegels. I know how to do that. My mom taught me how to do Kegels. So it's like, it's hard sometimes for them to comprehend. Yeah. But I absolutely love it when they come back and they go like, wow. Like, I'm just, like I'm floored. Like, I did not know that all that stuff was wrong. And like how much better I feel after all these things are also being addressed, right? And I tell my patients that endometriosis surgery, for when you do true excision, is only 20% of the pie. It's only 20% of the pie. Whoever tells you like, oh, I'm going to do excision surgery and you're going to be better tomorrow, that's a lie. And even I've had patients like, oh, I feel great. I was like, 6 months. Oh, I'm going to post a review tomorrow. I was like, no. Don't post any reviews. Wait 6 months until before you start singing anybody praises. Yeah. Right? Because you have to wait, which is why we have a lot of patients that have surgery, or I've seen a lot of patients that have surgery, and 2 months and 2 weeks later, post, oh, this is the best I've ever felt. And then 3 months later, they come and see me. Well, I just had surgery and it's all back to the same thing. I was like, no. Right? So we have to, we have to wait 6 months. And that's why I tell patients, like, no, you have to go with it. You have to go through the whole journey and then see how it comes out at the end, what improved. And one of the things that I'm telling patients is actually that I want them to keep a pain diary, because it's important. A lot of times when they're going through pain for such a long time, it's hard for them to, like, everything hurts, but they come and sit with me over here and they're like, what hurts? Where is it? I was like, I don't know, everywhere. So it's hard, right? Because then they're asking somebody that feels they're on the clock, which they never are with me. And I absolutely know that they're not with you, but, like, they feel that they're like, okay, got 15 minutes to talk to my doctor and tell him, like, a list of 17 questions. And I was like, first of all, calm down.
Yes.
We have an hour and a half. Just talk. Let's
Yeah.
just imagine you're talking to your friend, and I try to make it as light as possible, so that they can kind of, like, open up and tell me. But like, understanding the journey and their pain, and if their pain is cyclical or not, it's just such a big thing. And I
Absolutely.
think we should start sending patients, like, some type of pamphlet that talks to them about the nerves that are involved and where those nerves go, so that they can start tracking. Because a lot of the times I found that when I do telehealth for patients, and they come in, when I show them the pelvic dermatomes and they're seeing all these things, when they come to see me, they can say, hey, Dr. Henio, I have pain in everywhere with the lateral femoral cutaneous. And I was like, oh, okay, well, let's see. Or that's L4, L5. That is this, that's that. Like, that's ilioinguinal. Like, what is that? Where is that going?
Right.
Right? And it's different. And sometimes it's hard for them to understand that the pain that they're having down here may not originate from there, right? Because pain is just a response that the body sends you to tell you there's something wrong in this area. The problem is that nerve pain, the pain can be anywhere in that trajectory of
Right.
that nerve. So it could be down in the groin, but it could be actually a bulging disc in your back that's actually referring the pain down to that area, which is why sometimes we have to we could do blocks of that affected area, but that's only treating that area. But we have to figure out that whole trajectory of that nerve. And it sometimes requires us to send patients to go to orthopedic surgery or spine surgery, or get an MRI of the spine, right? So that they can actually see if there's any bulging disc, if there's something there, or if there's spinal compression that's actually referring that pain down to the pelvis. But that pain did not originate from there, right?
Absolutely, absolutely. And it's interesting how you mentioned the Kegels earlier. So again, the Kegels have this reputation of that's what the pelvic floor does,
Yep.
and that's what I need to do. But again, a lot of these patients, their pelvic floor is in this tight spastic place. So again, that doesn't mean they're strong, right? They're short, spastic, and they're weak. So they're not able to move and contract. So number one, the first part of it is getting that pelvic floor opened up so that they can contract and relax. And then I just saw a patient today who had excision surgery. She was doing great, was in physical therapy, and all of a sudden, because she was doing great, meds started being weaned down, but also she started working on some strengthening exercises. And she's like, and then all of a sudden my pain came back, and I had great months and I was doing great, and all of a sudden I'm back to this awful place. And again, she hadn't done injections or anything like that, but when I examined her, I was like, yep, these nerves are inflamed, but at the same time, there was multiple changes made at once between the changes in exercise. And again, your body's not at a place where it's ready to do these long-term strengthening. Strengthening is going to be an important part of that physical therapy regimen. However, when everything's not optimized yet, that change in activity and therapy is going to trigger things to go backwards, and it's going to feel like it's going backwards. It's like, okay, what's going on now? Because everything else hasn't been optimized yet. All of a sudden, these nerves are being squeezed, and they're reminded that, hey, I'm used to overfiring, and they're in this distressed place.
Yeah, well, I mean, in fact, it's funny, right? Because when they tell us that they do Kegels, the exact thing that we don't want them to do is Kegels.
Yes.
That's the number one thing. No. We do not want you to squeeze anything more. Like,
No.
no. and it's when I do the pelvic exam, like you said, like we're usually not putting before we do a pelvic exam, we're not using the big metal speculums or anything like that. Actually, we acquired a year ago the Seek really thin, slim,
Yes, I've seen
um,
those.
which is like they're phenomenal, right? Because they're thinner than a finger. It's a tiny speculum. It's like having a finger inside, and the penis it does not like light up all your pelvic floor muscles.
Yes.
Don't get inflamed at the same time. Which is why before we even put a speculum, we're actually doing a digital exam on the outside,
Mhm.
and depending on the score that they get with me, I may be a little bit more direct. Like you may need to go see Dr. Taylor sooner than you want to, but I think it's beneficial, right? So it's also important to like to talk to the patients about like their pelvic floor, like or what is pelvic floor dysfunction, um, and can't wait for a book that I read that I read, but I love it actually. It's one of my favorite GYN books for patients. It's called It's Not Hysteria, but Dr. Karen Tan.
Ah, okay.
Yeah,
That's
like I can't. It's. I don't know if it's out yet, but it's
okay.
just phenomenal. Like I got a copy. I've read it. I think I got. I was reading it slowly, but it gives me a lot of information of how to actually maybe change some terms and put it into way simpler ways that patients can understand. Right. So this is the book. It
Oh,
is. I
okay.
can't wait. I can't wait for it to be out so I can
I'll have to
recommend
share
it
it
to my
in a sec.
patients to get it. Because with this, they have a lot of they can arm themselves with a lot of knowledge about GYN, right? So that they can sit down and talk to their primary OBGYNs so that they can say, hey, like I'm having this, and that. What do you think? Is this endometriosis? No, 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 it's not endo. Okay, so if it's not endo, what is your differential? Why is it not in though. But this has a wonderful book here on pelvic floor dysfunction, like a chapter, a wonderful chapter, and I want my patients
Love
to
it.
like when this out, like I think they should definitely get it so that they can see and have that idea of what pelvic floor dysfunction is. So that hopefully they're not that hesitant. Oh, I don't want to do this now. Can I do it after surgery? I was like, no, you gotta go before prehab.
Yeah,
Yeah, I love it. I love it. I
that
love it. I love
is
it.
the, I don't know what word these kids are using these days, but that is it. Prehab.
Yeah, yeah. Prehab is it's the word of the
Yeah.
day of the week. Actually, I'm going to use that the whole week. Tomorrow, the first 7 patients I see, I'll say, "Are you doing any type of prehab?" They're like, "What is that?" And then let me tell you
Yes.
and show them.
Love
Yeah. Um. What? So what do you? So when do you recommend patients to start actually having um of sex after pelvic floor therapy? Or like, do you recommend anything for them in that? Because a lot of patients also want to do physical therapy to see if they could respond differently
it.
to sex, or how does that change for them?
For a majority of my patients, I don't give them any restrictions on intercourse for sex. So I say if you want to, you can. If you don't want to, don't force it. Because again, sex is so complicated. There's the physical aspect, there's the emotional aspect, there's the relationship aspect, there's, the psychosocial aspect to it. So if someone is wanting to have intercourse and they want to see how everything's working, I give them tips of caution, like use a suppository beforehand, communicate with your partner, things, what to expect and what not to expect, and if there's any other tools they can use to help with that. But if they're not wanting to, if they're anxious about it, I say don't force it until we're ready. And some patients may need extra support, including working with maybe a sex counselor, or using other tools, dilators, wands, before or after, suppositories before or after, or again, not being intimate in non-penetrative with non-penetrative
Well,
intercourse. So it varies.
that's
Yes.
good. That's good because a lot of the times patients, I do tell my patients that like being intimate with your partner does not mean putting something inside of something.
Right.
Right, it's a whole gamut. It's the way you talk, caress, how you text each other throughout the day. That is part of intimacy too. It's not only penetration, it's not only conquering something. It's a different gamut, and I usually tell my patients that especially after surgery and before surgery, that they have to absolutely forget this. Like, we got 5 minutes, the kids are sleeping, let's go. No, 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 no.
Right.
That has to be out of the equation. This has to be we're not a $3 beer, we're $900 bottle of wine.
Yeah.
So we have to be savored, right?
Yes.
So it has to go slow. It has to take its time so that you're not paying for it later, right?
Right.
And it's important. It's very, very important. And I love it when my patients come in with their partners.
Yes.
I just love that. I love it when
Yeah.
they come in with their partners, male or female, whatever it is, and they come in and they have that honest conversation and they're understanding the anatomy of why does it hurt? Why does it hurt? And then I get so excited after surgery when, and it's happened a couple of times, and I think I was going to say this before, but I got sidetracked. When a patient, like 6 months after surgery, says that the one that who can't hack it now is him, and I was like, wait, what? And then I understood, like, well, because, and it's understandable, right? If instead of enjoying intimacy, you're suffering through it, right? It's like you were, and you have endometriosis on your uterosacrals,
Yes.
and you're having so much pain at deep penetration. It's like being intimate with both hands behind your back, right?
Right.
But when you suddenly are enjoying intimacy,
Right.
and you're not having pain, and you're suddenly being more open and, okay, no, 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 I want things this way. So it helps a lot. Like, when do you believe that patients should resume pelvic floor physical therapy post-operatively?
Usually I do defer to you, the surgeon, because again, depending on the approach that you used, if there was hysterectomy, vaginal, all of that, I usually defer to you. But certain things like the breathing techniques, you can start that, day one.
Yeah, yeah.
Those simple things, I would say, start right away.
But that's the reason why I want them to see you before surgery, because their post-operative period can be severely improved by breathing,
Right.
by just understanding how to relax their pelvic floor.
Exactly.
So all those things significantly help with
Prehab.
function, with prehab. Exactly, the prehab. That's it. It is. They just help with
Right.
function. They help with everything, and patients do really, really well. What else? What else should we talk about today?
What else? And again, going back to intercourse, like you mentioned before, pain upon penetration is very different than deep pain, and that's also separate from, ONUT is one of those tools that I can recommend. And then it's different from pain after intercourse, because some patients will say, I don't have pain during intercourse, it's the next day that I hurt more. And again, it shows kind of the reason why, whether, again, is it a vulvovaginal penetration issue? Is it a deep, nerve tension issue? Or is it that, the climax and those pelvic floor muscles contracting and overactivating things, that's a big contributor? Or it could be all of those separately or all of those together in combination too.
Together. Yeah. Okay. So it's very important, and you just mentioned this, like, I usually tell them to go back to you at, like a month to 2 months, depending if they had a hysterectomy or not. If they had a hysterectomy, since I don't want them to lift anything over 20 pounds for 6 to 8 weeks, I usually tell them to go back to pelvic floor after 8 weeks, but maintain doing the breathing exercises and all these other things, and just to have that pain calendar from day. Just keep that pain calendar, because you can see, okay, I'm no longer having pain every 3 days or every 5 days, right? So it's very, very important that they understand their body and they separate things into the categories that we ask them. So before patients come to see us, they filled out a massive questionnaire of a lot of validated questions so that we have a better idea of every little topic that's going on, and we can go from there. Right. So it's very important for them to understand this so that so things can move forward in a better way. Now, this is something that I tell my patients to use a lot, even before surgery, after surgery, but more importantly, in some of those patients that which we see a lot are patients that have a hysterectomy, They have massive endometriosis, and their local GYN, the local OBGYN obstetrician would basically do a hysterectomy that is supposed to be simple, but then everything is stuck together. They're able to pull off the hysterectomy without any major complications, but they left everything that was stuck to the back of the vagina there. So that patient would usually come back to me and they would say, "Hey, I don't have a uterus, but I have a magical monthly period. What do you think it is?" And I usually say something ridiculous like, "I don't know, Tinkerbell? Like, I don't know." But then when we start doing the exam and I show them the thickness of the vaginal cuff, they understand that at the time of the hysterectomy, they left massive nodules of endometriosis behind the vagina. And then that's where they actually start having a period, even without having a uterus.
Right.
Right. So if those patients that I see, or patients that have had in vitro fertilization in which they have extensive endometriosis, they put a needle, right? So when they're doing IVF, they put a needle through the back of the vagina down over here to get into the ovary.
Right.
But if there's endometriosis over here, all these things would get infected. Like you can actually see an endometriosis, and I have multiple videos that I'm pulling together of all patients that had IVF, and they had massive endometriosis, and now they have an infection that is protruding through the whole vagina. So that means that at the time of their hysterectomy or their surgery, they're gonna need a partial vaginectomy. We're gonna have to cut a piece of the vagina out, which is gonna make their vagina shorter, which can impact themselves through sex, which is why again I say this.
Yes.
Right? The O nut is phenomenal for that to limit penetration. But it's also important for patients to understand one thing. There's a difference between insertion and deep inside. And a lot of our patients tell us or ask the question, "Okay, are you having pen with sex?" "No, not really." And I ask them, "Are you limiting what you guys are doing in sex? Are you doing position number one and position number two and then forgetting every other number in the universe? Because this is what you've learned that you can do so that you can survive the event."
Yeah.
That's not the same as not having pain. But if while if you're being intimate with your partner, you're more concerned about surviving than enjoying it, means that you're actually making sure that you're there and feeling everything at the same time, so that you're not no, don't go that way. Stay here, because if not, I'm gonna have to pay for it tomorrow, right? So that is not the same as not having pain with intimacy.
Right.
And that's important for patients to distinguish, right?
Absolutely.
Well, what else?
I'm going to check and see if anybody had any questions. There was a question about pelvic rehabilitation in California. We do have a LA office. Dr. O is there. It's our newest office. Is this being recorded so I can watch it later? I'm not as savvy on Instagram, but I think it is. It's going to be saved. So we'll be able to post this later. Let's see. See some familiar names. Hi to you all. There's a process to recover after surgery from all the trauma. Absolutely. Again, it is a journey. I always tell patients, I wish it wasn't a surgical diagnosis but that's the beast of endo. And again, injections, while we try to make it as comfortable as possible, a needle is still a needle.
And something important that we need to make sure that patients understand that there is a very important thing that they need to do. It is therapy, but not physical therapy, mental therapy, right? Because if you've accustomed yourself through living with pain through years of your life, you have to undo all that trauma that you've had, all that negative self-talk that you've done to yourself, because it's almost impossible to live throughout all this ordeal, through all this pain, and not have some type of negative self-image or negative self-talk. So one of the reasons I got into this is because of our patient, right? And living through years of pain definitely does something to your ego, to your psyche. And that's something, it could go to the very depths of hell, which is why it's important to talk to a therapist, get some emotional support, and then make sure that you're fostering a group of people around you that actually validate and see the pain that you're having, right? Because a lot of the times, a lot of patients with endometriosis, they go to work and they do the best they can, and within their circumstances, right? And sometimes they get fired or they get talked down at work because they miss it, because nobody sees it, because it's an internal disease, right? So they have this dark room in their hearts that they're living in, and suddenly a lot of them after surgery and therapy open up the doors and then have the ammunition to tell patients, okay, the people, that, hey, listen, I'm not defective, I have a disease, and it's a chronic disease, and then this is what happens. And they can show, but it's important. One of the things I tell them in their videos, because I do a video for them after the end of the surgery while I'm talking to them, well, I give them their 20, 40, 50, 100 pictures, and I say something as simple as, congratulations, you're not crazy. And then seeing their partners cry after they see all the disease that was removed,
Yeah.
or all the stuff that was done, it's heart changing, right? It's heartbreaking that some patients are very lucky and have really wonderful partners that they understand and believe them despite the fact that they can't see the disease.
Absolutely.
Right? Other patients have partners that are, it's a lot more difficult for them to understand it, but then when they see the surgery,
Right.
and they see the ovary stuck together and it's not moving, they're like, oh my God, what have I done?
Mm-hmm.
When they see what normal looks like and they see what their partner's living through,
Right.
they break down, and it's hard, but it's also liberating for the patient to see, like, okay, like, there is something wrong, I'm not crazy, it's not in my head, right? So that's, I think that's the most beautiful part of what we do, is just giving patient back their lives, like the possibility of being intimate with their partners and have fun and enjoy everything, and to have and give them hope, right? Preventing patients from self-harm is just a wonderful thing for me. And if I can do anything to prevent any other patient from self-harming because of endometriosis or this pain that they're told is in their head and they're crazy and they're just whiners, like, that's all I want.
Right. Giving that hope back, that confidence back, that quality of life, and, you know,
Yeah.
having that power back for themselves.
Giving hope back to the hopeless. It's to people that are hopeless is just a beautiful thing.
Absolutely.
But with that, it's been an hour.
Yes.
It's been super. We should do this more often. Like,
We really
I know
should. We really should. I
should
know
this
we've been
more
talking
often.
about it. We
Yeah.
should just kind of make it into a little series, have little nuggets here and there.
Got it. Well, let me see. I would have visited you this week, but I'm actually traveling to do some endometriosis stuff outside of the country, so I'll have some fun there. I'll go back to the Dominican Republic for the weekend.
Okay. This is
And
amazing what you do. It's amazing.
It's amazing what they do. It's amazing what the team over there, the endometriosis Dominican Republic, endometriosis Antioquia, endometriosis Mexico, endometriosis, living, and the team of endometriosis that is just all throughout the world, all the wonderful endometriosis advocates that we interact. In 16 years of endo, just so many of them. Endo Sapota, like, we just have so many different, such a great different team of advocates for patients and that share adequate information. And we're combating a very dangerous narrative that endometriosis is the endometrium. Right? There's still, in this day and age, people that are saying endometriosis, it is the endometrium, when we talk and talk again and tell them that is not. So, that's what we're fighting with. That's what we're fighting with. So we cannot stop, because the moment we stop, they win.
Yeah. I mean, in medical school, I think I got maybe a few lectures on endometriosis, told it was zebra, you'll rarely see it. I asked a current med student how much endometriosis, she's like, none.
1 hour?
1 hour, maybe.
1 hour.
Yeah.
That's all I remember from high school. Well, this is endometriosis, it's here, this is that, and this
Here's a chocolate cyst, yeah.
This is chocolate cyst, and you treat it by cutting out the ovaries and castrating women like dogs. I was like, oh, okay. Actually, I got it into trouble a couple of years back because I was doing a conference outside of the U.S. and one of the doctors stood up after seeing some of the videos that I shared in the conference and said, like, well, I mean, this is really complicated. Why don't we just cut out their ovaries, and then that way everything's gonna be fine? And I told him, if you had a disease in the tip of your penis, would it be okay to cut your testicles too? He could not understand that I asked him that, but it's the same thing, right? Because just because you can't see it doesn't mean that you're okay just chopping organs for no reason, right? You have to have a really good reason to cut out ovaries and castrate women. Because what happens a lot of the times is, and I saw that in the Midwest, is that you had a patient that had endometriosis in their mid 20s. They may or may not want to they may want it to have kids. And then what happens? They go, you know what? This is going to be too hard. Let's just castrate you like a dog. Well, they don't say that. They say, let's take out your ovaries. Then they take out both of your ovaries. And then they take out your uterus. So you have no uterus, no ovaries. But they left all the endometriosis behind. And then what happens later? When you go back to them and say, hey, doc, my inflammation is down because I don't have any ovaries, so inflammation can go down. And the chronic inflammation that you get from having active endo goes down, right? But that's not the same as treating the endometriosis. So what happens when later on they go back and say, hey, doc, you know what? I don't have any ovaries, so that means that I don't have any sex hormones, so I don't have any desire to have sex. I see my partner coming towards me, and I'm like, put that away. I'm not in the mood now or ever because I have no sex hormones, right?
Yep.
And then they go and say, and they go back to their GYN, and their GYN feels really bad for their partner that now have a patient, right, that has a dried up vagina because they're absolutely hypoestrogenic.
Right.
So they give them estrogen, which can actually activate all the endo that they left behind in the first place.
Mm-hmm.
And that is, say it with me, bananas.
Mm-hmm.
Like, I don't know what to do. Like, it's just crazy. It's just crazy, crazy, crazy. But
on that
it will
note, I
get
saw a
better.
question earlier. Someone asked about should they have their eggs frozen before excision. What are your thoughts on that?
What was the question again?
If you recommend having eggs frozen before excision, I think
So
let me see.
it all depends on if you have endometriomas or don't have endometriomas,
Mm-hmm.
right? And the fear of having we have to play devil's advocate. So if we look at if I would put an REI cap on, which I'm not a reproductive endocrinologist, but if you put a reproductive endocrinologist hat on, their fear is if this patient goes for surgery and they see a lot of endometriosis in the ovary, what's going to end up happening is that some OBGYN is going to cut out the ovary, and then I'm not going to have anything to be able to get this patient pregnant. So they're like, no, 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 no. Let us do the stimulation first, remove everything that we can, and then if you go for surgery, if they cut out the ovary, who cares? Because we already have some eggs, right? But that means that they're gonna stimulate your ovaries to produce a large amount of estrogen that's gonna go everywhere where there's endometriosis, and it's going to really get it mad.
Right. And
so every portion of endo that's saying it nicely. It's just gonna get all the endo mad.
Yep.
If it's on your diaphragm, if it's on the intestines, if anywhere it is, it's just gonna get way worse. Now, but I understand why they want to stimulate patients before surgery, because most of the time, or 99% of surgeons are going to cut out the ovary if it becomes too bad. So they're not going to have anything to stimulate in order to try to get you pregnant, right? Now, my excision surgeon would tell me, let me go inside and try to save this ovary and be meticulous with it. And it doesn't matter that's going to take me 10 minutes or it's going to take me 1 hour to save one ovary. It's worth it. So we'll go very slow to cut out the ovary, cut out the disease from the ovary, save multiple spots of normal ovarian tissue, and then repair that ovary and get it into this nice little ball so that when you get stimulated, the endometrioma is out, or the possibility of forming an endometrioma is not there, or significantly decreased, so that you still have something that they can stimulate, right? And your AMH would go back up over time, which is done, but it all depends on how was the surgery done, how was your endometrioma resected without cutting out the ovary,
Right.
right? So that's kind of my thing.
Oh, that's amazing.
Let's see any other questions. Oh, what is the difference between Da Vinci robot method and haptic incision method for endometriosis surgery? So there's a lot of fights that we have with like straight stick surgeon and robotic surgeons, and it's usually more ego thing. It's not, there's not a big difference. The best thing is, what does your surgeon feel more comfortable doing, right? I can do any type of stage 4 surgery laparoscopically than anybody could do with the robot. Now there's one situation when I think the robot is way better, only one, and that's on when you're doing diaphragmatic disease that is behind the liver. So that's the only time where I usually would like have the patient come back, put a robot in so that I can lift the liver. But that is if I have endometriosis, that I have to mobilize the whole liver ligament to get behind the liver and cut that endo out. Or for example, today, my patient today had that had massive endometriosis, and then when I'm looking and I lift the left edge of the liver right under the heart, she has a big plaque of endometriosis.
Mm.
In this case, unfortunately, I didn't have a CT surgeon on standby. And the patient, before that, they need to have a special tube that separates their right lung from their left lung. Because when we get over here, they can have a lung collapse, right? So those are the situations that the robot, I think, has a much better advantage, basically for diaphragmatic disease. But I have not encountered anything that I have done laparoscopically that I think the robot would be better at. But that's just me. But there's other doctors like Dr. Vidali, Dr. Megan Wasson, Dr. Megan Luna, who do things with the robot that for them is actually good. But for me, I think there's nothing to beat straight stick and the laser. But besides that, that's it. So no more else.
Awesome.
Guys, it's been good. Yugita,
Yes, it's been wonderful.
have a wonderful rest of your day, guys, and I'll see you soon.
All right. You have a good night. Bye, everyone.
Bye bye.